Hello, I'm Esma Campbell, Cardiovascular Interventional Science Program Coordinator at Armstrong State University. Almost said Atlantic, sorry. Our objectives today will be to review the evolution of coronary revascularization, coronary artery bypass graft surgery, coronary artery balloon angioplasty, coronary artery stenting, bare metal stents compared to drug-eluting stents, coronary artery revascularization, and patient outcomes. A lot of what we see in cardiovascular interventional science today is the result of the pioneers who spent many hours before they had the technology to really assist and provide them with the tools they needed. One of the ways that they learned a lot about the cardiovascular system was by dissecting it and then doing drawings of what they found. I'm sure we've all heard of the great artist Leonardo da Vinci, who lived between 1452 and 1519. He was an amazing scientist and artist, and if you look at anatomy and physiology books today, you will still see very meticulous drawings that he did of the heart that are still very useful in practice. The cardiovascular system, what they determine, is a system that operates in a state of ceaseless motion. A ceaseless motion means that if there is any kind of obstruction, if there's any valvular issue, if there's anything within the system that causes a change in that ceaseless motion, the patient is going to become compromised. So in the beginning, just some of the simple ways that they learned to study the human body. We had Christopher Wren as far back as 1632 looking at ways to outline the blood vessels, and clearly these were going to be on cadavers. They would take hollow reeds and use colored dyes, inject these colored dyes, and then look at the cadaver and see where the dyes ended up into what target vessel or target organ. So they early on decided that to review and learn about the cardiovascular system, they would need to come up with methods to inject into the cardiovascular system. And this is what they were doing in the 17th century. I don't want us to get completely focused on the cardiac part of this career, because cardiovascular interventional science not only involves the cardiac system, the pulmonary system, but it involves studying and diagnosing and treating every single blood vessel in the body. That includes the carotid arteries that supply the neck and the head. That includes all of the organs that supply the abdomen, including the kidneys, and that includes all of the vessels that supply the lower extremities. As you would guess, obstructions or disease processes in any of these will severely compromise a patient. So once again, they would take various dyes that they injected into the systems and study the tissues once they had injected those dyes into the system. Even though you may not be very interested in the history, if we look at the history and how cardiovascular science began, what we do today is truly just a modification of the techniques that were used early on when they began this career. How did the birth and evolution of angiography actually come to be? Well, we talked earlier about how they were injecting different substances into blood vessels, but the only way to actually study those was to look at them with the human eye. In 1895, when Wilhelm Conrad Röntgen, one of the reasons we're all here, discovered X-rays, his combination with being able to inject different substances into blood vessels was actually the birth of angiography. So without Röntgen's contributions, we would not be where we are today. Angiography has a very specific definition. It is the X-ray visualization of the internal anatomy of the heart and blood vessels after the intravascular introduction of radiopaque contrast medium. Long definition, it simply means that with X-rays and with introducing a contrast substance into different blood vessels and following them to target vessels, we have angiography, or the ability to view real time what's going on with patients. So we take this angiography, we inject it, we take the contrast, we inject it into the blood vessels, and then what we're actually looking at sometimes is the blood vessel where we inject it. Sometimes we're actually looking at the target vessel where the contrast will end up. Clearly, this has to be done in a very safe environment and in a way that is very time effective, because, as you know, the blood moves very quickly through the body. We can inject either intravenously, depending on if we're studying something that's a part of the venous system, or we can inject through an intra-arterial system if we're studying something that is going to be a result of an arterial occlusion. So you have to know where you want to end up before you decide where you're going to be to start with. All sorts of things can go wrong with the cardiovascular system. You can have areas in the body that bleed. You can have areas in the body that have tumors. You can have areas in the body who actually have disease processes going on within the blood vessels. So what we do is inject, we use these studies to image the blood vessels everywhere, in the abdomen, in the cerebral circulation, the peripheral circulation, cardiopulmonary circulation, and this has to be done by injecting a contrast substance. A little bit more history. We won't go into a lot of detail, but in the 1900s we had Walter Dandy, who began to do a lot of work, and he developed a technique to introduce air into the ventricles of the brain for visualization in living subjects. And his procedure that he developed was pneumoencephalography. This was really somewhat a barbaric procedure. It was a very necessary procedure. If you've ever heard of babies who have water on the brain, it means that they have something wrong with the ventricles in their brain, and that has to be addressed, and they have to figure out what's going on. Once they came up with pneumoencephalography, they decided that it would be interesting to see what other substances could be safely introduced and what structures you could visualize as a result of introducing these substances. So where we have an image of a pneumoencephalogram, this is probably a very old image because pneumoencephalograms were probably not done after about 1979, 1980. And the way they were performed is a person was put into a chair, basically strapped into a chair. I hate to say this, but it looked a little bit like an electric chair, and their back was exposed so they could do a lumbar puncture. Cerebrospinal fluid was taken out and air was replaced, and as you can see in this image, we have air in the ventricle of the brain. And what they would do is then spin that patient into different positions, and they could watch this air move. It was very hard on the patients. I don't know if any of you have ever had a terrible migraine, or if you've had a terrible or had an experience with a lumbar puncture, but anytime you remove cerebrospinal fluid, you lose that cushioning to the brain. So it was a very hard procedure for patients. They became very sick, usually did projectile vomiting all over the room the entire time you were spinning that chair around. And then along came EMI, which was the first EMI CT scanner. And some of us were very, very delighted when CT scans came to be, because that did away with our need to do pneumoencephalography at that point in time. So CT had a real role in taking away some of those procedures. Here we have an image of an abdominal aorta runoff. It's an angiogram of the lower extremities, and you can see the aorta here, and you can see both sides of the vascular tree going down into the legs, and you should see a nice steady stream of contrast. Here where we have the arrow, it's a very small stenotic area, And that is something that can be corrected either with a balloon angioplasty, which we'll discuss, or the placement of a stent. So just to show you that we do these procedures all over the body. Lots of patients who are diabetics will have many problems with the smaller vessels in their lower legs. Many of them end up with situations where they get gangrenous lower extremities, and restoring blood flow to these areas becomes very critical. Here we have just an example of an angiogram of the internal carotid artery, and you can see all of the vessels that supply all of the parts of the brain. It's very important that this blood supply is here, because if not, patients will have some kind of a neurological deficit as a result of that. Here we have an image of a vertebral arteriogram, and the vertebral artery is what actually supplies the posterior portion of the brain. Very hard to get to surgically if there's anything wrong. Sometimes you can do procedures that are catheter-based rather than surgical procedures. And here we can see all of this staining, and this is actually an arteriovenous malformation. So that is a terrible communication, improper communication of arteries and veins, and can cause patients lots of problems. There are multiple ways to correct those. You can sometimes do them surgically, or sometimes you can use catheter-based procedures and use a catheter with embolic substances to occlude the vessels that are feeding it, and then hopefully you can resolve it. If not, they can still take the patient to surgery, and hopefully they will not lose as much blood as a result of that. In the 1920s is when we really began to study and find different options for injecting substances safely into the cardiovascular system. Sodium iodide is what they were using initially to look at imaging the femoral arteries. And once they came up with solutions that they deemed safe, then they became a little more brave in extending that and looking at different parts of the body. So there were lots of changes between 1920 and 1970. We had better imaging equipment. We had much safer contrast agents. We had safer catheters and tools that we use. And so that was a very important period in the development of cardiac catheterization and angiography. This is an important story to me. In 1929, there was a resident who was in Berlin. His name was Werner Forsman, and he was a very bright man. He was searching for methods to deliver medication directly to the location of need. And he felt like if a patient became compromised from a cardiac standpoint, if you could deliver medication directly to the heart, you would be more effective than if you were delivering medication through an IV in the arm. And he is the one who's actually credited with performing the first cardiac catheterization. So he was 25 years old. He was receiving his clinical instruction in surgery near Berlin. He, on himself, passed a 65 centimeter rubber urological catheter through the vein in the elbow of his arm, his antecubital vein. He guided it by fluoroscopy and until it entered his right atrium. He then walked up a flight of stairs to the radiology department for a chest radiograph to document the exact location of the catheter tip. And this is actually a copy of that radiograph that was taken. You can see the catheter coming up through the arm here and going around and sitting down in the right atrium of the heart. He lost his position as a resident. They said that he had done something that was terribly unsafe, and so he did not get to continue his education there, but clearly he went somewhere else and did some exciting things. So his quote was, "If cardiac action ceases suddenly as is seen in acute shock or in heart disease or during anesthesia or poisoning, one is forced to deliver drugs locally. In such cases, the intracardiac injection of drugs may be life-saving." And that was his entire goal. and why he wanted so desperately to find a way to get to the heart. So in the 1950s, we started seeing different things happen. That's when the rapid development in cardiac catheterization and angiography began. Prior to 1953, they had been doing a cut-down approach when they did these procedures, which was very time-consuming. It became more of a surgical procedure. You had to completely expose the artery or vein that you were working on, and then at the end of the procedure, all of those layers of tissue and fat and skin had to be sutured back. In 1953, Seldinger came up with a percutaneous approach, which we still use today. And it was a very simple approach. He would anesthetize the skin. He would make a needle puncture into the artery or the vein with a needle. He would then put a wire through that needle, pull the needle off, and then put the catheter over that needle. Very quick, very simple procedure, and you no longer had to do the suturing part at the end because it was a little like just a very large IV. We still use that technique today. The only thing that's been added is we use a sheath with this technique instead of just using a catheter. And once you get the sheath in, or the introducer in, and you can change catheters as many times as you need, and that reduces the trauma to the vessel. In 1959, they had not been very successful in being able to selectively catheterize different vessels, and in 1959, Mason Sones was able to do that. He came up with a technique to cannulate selectively each of the coronary arteries. And then in 1967, Melvin Judkins refined this approach and even came up with additional catheters that made it possible to do that. So if you think about all of the blood vessels in the body, and we said that we're going to introduce these catheters and take them to target areas. If you think about all the different organs, all the different places it needs to go, then you have to have lots of different curves that you can get to all of these different pieces. The catheters that we use in the cath labs today still carry the name of Dr. Judkins on them. They're JL4s and JR4s. In 1970, we had a couple of physicians, Swan and Gans, who introduced a flow-guided catheter for use inside and outside of the cardiac laboratory. And the Swan-Gans catheter is used when we look at the right side of the heart. The right side of the heart is the part of the heart that has the where the inferior and superior vena cavas enter in. It has the right atrium, right ventricle, pulmonary artery, and out into the lungs. It's very important to be able to study that side of the heart also, because that is the side of the heart where you can have pressure abnormalities, you can have what we call holes in the heart, like ASDs and VSDs. So we needed a way to introduce this to study that part of the system. Today, there are over 2 million of these procedures performed each year. Here we have an example of a Swan-Gans catheter that those two physicians developed, and it does look a little daunting. You have all of these different ports, and it's basically every one of these ports ends up being a small catheter within a catheter, and the different ports have different exit areas throughout the length of the catheter. So you can be measuring something at the tip, and you can also be measuring something in the right atrium. We use this catheter a lot when we study cardiac output, and cardiac output is actually one of the most important parts. It talks about how much blood your body is actually pumping out with each over a minute, which becomes very significant to patients. Here we have an angiogram of a left coronary system. I know you all watch television, and if you've ever heard some of St. Joseph's commercials, you'll hear them talk about a widowmaker. And a widowmaker is when you have an occlusion or a stenotic area here in what we call the left main. It's a very short segment that begins the left coronary system. if you have an occlusion here, if you have a stenotic area here, if you look everywhere that you have contrast flowing in that heart, if this is suddenly cut off, then a large part of your heart is not going to get blood supply. We have the left anterior descending, we have septal perforators, we have diagonals coming off. This is our left circumflex artery, we have an obtuse marginal. All of these vessels have names, not really significant to you, but all of these vessels are important to feeding the myocardium. If you hear of someone who's had a heart attack, who's had an MI, then what has happened is in one of these vessels that supplies a portion of that heart, for some reason that blood supply has become interrupted. Here we have a right coronary artery, and it supplies a different portion of the heart. It doesn't supply as much of the heart. It does supply some of the structures that provide the electrical conductivity to the cardiac system. It's very significant too. It just doesn't supply as much of the heart as you see here with the left coronary system. When we do a left heart cath with coronaries, we are looking at the left coronary artery and the right coronary artery, but something else that's very important is looking at the left ventricle of the heart. The left ventricle of the heart is that structure that squeezes and pumps blood out throughout the rest of the body. So here we can see the diastolic phase of the left ventricle of the heart. That is when the left ventricle is filling with blood, that hopefully we will get a good systole or a good squeeze, and that blood will be ejected out through the aortic valve into the aorta and then subsequently throughout the body. Here we can see the systolic or squeezing part of that cardiac phase, and that's what we want to see is, good contraction and what we say good wall motion. We don't want on systole to see this wall stay here. You can see how it's moved here. And that's what we want. We want to have good contractions with each cardiac cycle. As this field grows, it becomes more and more the drive to be able to study structures of the heart, treat structures of the heart and the cardiovascular system by less invasive approaches. And that means procedures that once were done only in a surgical suite. Now we've been able to come up with the percutaneous approach, going back to the Seldinger approach that we talked about that came to be in the 1950s, and not have to send patients for very invasive surgery. So the ability to perform very safe angiography, both cardiac and peripheral vascular, was really the basis for transitioning more from a diagnostic approach to now a very rigorous therapeutic approach. So just about all of the procedures today all the procedures that we've talked about today are transcatheter procedures. That means these procedures can be done in an interventional radiology suite. They can be done in a cardiac cath lab. Sometimes they're performed in what we call hybrid rooms, where you can do any of these procedures in any room. One of the big advances was in 1977 when a very brilliant man, Andreas Grunzig, performed the first PTCA, or percutaneous transluminal coronary angioplasty. He actually developed this balloon catheter in his kitchen and then was quickly snatched up by a company, and then they began to market that. After we had PTCAs, we had a terrible problem with PTCAs and those vessels closing up again. So the next phase of the technology was to come up with stents that would open the vessels and hold the vessels open. And then the next step was a procedure we call atherectomy, where we actually go in with a device that functions at about 168,000 RPMs and shaves away calcium within the vessels. Not only have we come up with lots of different devices that we use, but all of the pharmacologic agents have increased in efficacy in the last 15 to 20 years. We have lots of agents that we can give patients that will reduce thrombus. We also have different pharmacologic agents that we can use when we're trying to do embolizations or reduce the blood flow to a particular area, for instance, a brain tumor or an AVM if the patient's going to have surgery and you want to reduce that blood loss during surgery. So in the late 1950s, we had coronary artery bypass grafts come to be. They were primarily being done in Europe at the time. In the United States, it started around 1960. They started in Savannah in the late 60s, which I think is pretty good. We had a phenomenal surgeon here who had very good outcomes. And 20 years later, you could look at his bypass grafts, and they were as pristine as the day that he put them in. And then the other advancement that we talked about was balloon angioplasty with Andreas Grunzig. He ended up going to work as a lead investigator and cardiologist at Emory University. He was a private pilot, and unfortunately in 1985 he was killed in a plane crash. Here we have an example of a right coronary artery, and you can see in the post film what it should look like, but it is occluded right here. It's totally occluded at that point. So what would happen is you would take a very thin wire, not much larger than a hair, and you would advance that wire down through the right coronary artery. You would then put a balloon at the site where it is occluded. You inflate the balloon with a special device, and it pushes the plaque back into the walls of the vessel, and then hopefully you can restore blood flow to this area. Balloon angioplasty in the beginning, you had to be very careful with your patient selection. They primarily treated single vessel disease because there was such a high rate of restenosis. Today, because of the different tools that we use, we'll treat just about anything, even triple vessel disease. The outcomes related to balloon angioplasty, which was our first form of revascularization that was available, was about 40% restenosis rate. And then we came up with bare metal stents, and they were better. The restenosis rate was 20 to 30%, but that really wasn't very good. You still saw a lot of these patients come back. As they continued to work, they came up with a stent that actually had a polymer on it with a pharmacologic agent embedded in that, and it prevented the growth of scar tissue in that stent and was able to reduce the restenosis rate from 5 to 20%. And that's what we're currently using today. And here we have an example of what a stent looks like. It is sitting on a balloon that's expanded. So when you put this into the patient, it doesn't look like this. It's all very flat. You inflate the balloon, which you can see here, and then you inflate the balloon. It deploys the struts of that stent into the blood vessels. You deflate the balloon and pull the balloon catheter out, and the stent stays in the vessel, hopefully maintaining an open lumen. In the future, we hope to see, well, they're already working on biodegradable stents. So this stent, this metal that you see here, that in the future they want stents that will do the job for about 6 months and keep the vessel open, and then hopefully will biodegrade after that time. And we continue to develop more effective pharmacologic agents that fight plaque, fight thrombus, and keep cardiac and peripheral vascular patients from having such advanced disease. So after all this history and information on technology, what does a cardiovascular invasive specialist actually do? This is a role who actually ends up being 3 different people. They're divided into 3 roles, and in the course of any day, you're going to rotate through all of those roles. This person records and has to be able to read an EKG as well as a physician can. They're going to record and understand the pressures in all of the different chambers of the cardiovascular system. It's very important for them to communicate with staff anytime they notice something that's a change in the patient. And they're also responsible for adjusting all of the imaging parameters as they acquire the images for these studies. The circulator is the person that is going to record some of the procedural events, administers all the medication. They're going to process blood samples that you may do either for oxygen content or to evaluate the coagulation status of the patient. They're going to be there to open supplies, and if that patient begins to deteriorate, the circulator is the person who will first begin to deal with that emergency situation. This looks like a really simple slide. The scrub person will work at the table with the physician, assist the physician in exchanging wires and catheters, and assist with contrast injections. This scrub person, however, really has to have the basic knowledge that the physician has with all of the equipment, has to understand equipment compatibility, really is crossing over with the role with the physician in many of the techniques that they use as far as moving the wires through the coronary arteries and through the different vessels that they're trying to revascularize. So this person, even though we only have 3 bullets here, those bullets are truly loaded bullets. So we've really transitioned from just a diagnostic to an interventional world. This occurred back in about 1970 to 1980. All the staff were expected to take on additional responsibilities because no longer were we doing just simple diagnostic cases, but we were doing very complicated, complex cases, cases that patients many times had very serious outcomes, would go into cardiac arrest, and all of those make that world just a little more complicated. Ischemia or a reduction in blood flow to different areas in the vascular tree became a real problem. They were responsible for all the pieces of the cardiac roadmap, recording and making sure that they had a good record of all the inflation times of the devices they were using. They had to evaluate the left ventricular ejection fraction and do a lot of quantitative coronary analysis so they were sure that they were using the right tools and stents and balloons. In today's world, we also do a lot of medical management with the patient when they're in our areas. We are able to give them more sedation. We do something called ACT, which is activated clotting time. That's a piece of point of care testing. We won't go into a lot of detail of that, but it's actually testing of the blood at the point of care, and it's very tightly regulated by the state. So instead of sending the blood to the laboratory, which would not work in these situations, it's actually done in the room. So there are all sorts of regulations along with that may create all sorts of rules you have to follow. Because of the procedures that we do, we give them a lot of anticoagulation therapy in today's world. We do a lot of thrombolytic management, which means patients who have blood clots in different areas, we use different agents to lyse or break up those clots. We do a lot of what we call 2B3A inhibitors, and this is where once a patient has an event and they are having an MI, the body immediately wants to clot that area off. It thinks it's taking care of it. So the 2B3A inhibitors are pharmacologic agents that prevent this from happening because we don't want blood clots to form in those areas. We also have a way to better assess what we do in the actual vessel when we have deployed a stent, and that is intravascular ultrasound. And then we have lots of bailout devices like intra-aortic balloons when patients go into severe situations like cardiogenic shock. The environment is a sterile environment. Everyone has to be quite cognizant of that. You can see here you have your image receptor at the top. Underneath this table you would have an X-ray tube. If you look here, you can see that they are watching live images as they manipulate this catheter into the blood vessels, into, in this situation, the coronary tree. You can see they're wearing sterile gloves, sterile gowns, hat and mask. They all have on thyroid shields. So it's an environment where not only do you have to focus on the patient, but you have to focus on all the equipment that you wear, all the equipment that's in the room to prevent any kind of infection for the patient. There's a lot of technology in every discipline in this department. I think it's very easy for people to forget that regardless of the technology you have, if you don't have people caring for patients, if you don't have kind caregivers dealing with patients, patients will not do as well. You never allow machines to assess a patient. They are simply tools. You cannot replace that human factor that is assessing that patient to make sure that everything is okay. Radiation safety is a huge issue in these areas. If you're not careful, you can very easily receive more radiation than you should. ALARA is I'm sure you've heard it before, as low as reasonably achievable. It's a very important piece of radiation safety. You have to be fully aware of where that x-ray tube is. You have to follow very strict radiation safety guidelines, or you will put yourself at risk. You can put the other people in the room at risk, and you can certainly put the patient at risk. So it's a discipline where if you're not going to pay close attention to that, it's not going to be a safe environment for you to be employed in. Here we can see a staff member who has on a lead apron, and in addition to that, she has on a thyroid shield, which is very important. And most people in these environments, in addition to that, would also wear lead glasses to protect their eyes from the radiation too. So here we have an example of a radiation burn. This is a situation where the patient was receiving a stent, and for a very long period of time, the x-ray tube was in the very same position as they continued to image. This was in the earlier days when the stents were a little more difficult to see radiographically on your images. But you can see that we now have a crater in this patient's back. The problem with this patient was they went to their physician, their attending physician, after they left the hospital for their cardiac procedure, and he had no idea what it was. He just didn't put two and two together. And he came back to see us later, and as a result, as soon as we sat him on the table, we knew immediately what had happened. So anyone dealing with ionizing radiation should never get so cavalier that they think in today's world it's very safe and nothing can go wrong. If you would just kind of keep this in your memory banks, because if you're not careful, things can go very wrong. For cardiovascular technologists, you have to have a very broad knowledge base. You have to have a very high degree of manual dexterity. You have to not only have the ability to work well in emergency situations, but you need to love to work in emergency situations. Those patients who are going into very dangerous cardiac situations, you have to be able to take care of them and love every minute that you're doing it. It's a very demanding field emotionally, very demanding field physically. These people are on call. You'll have a call rotation that you will have to rotate through. And that means that when you've worked from 6 in the morning until 7 at night and the phone rings at 2 a.m., you have to be able to hop out of the bed, be at the hospital in 30 minutes or less, and be able to function just like it was 2 in the afternoon. Certification through CCI, Cardiovascular Credentialing International, is a certification that is recognized as the appropriate certification for cath labs throughout the country. You will not be able probably to find employment if you do not take your boards. Here's just an example of a specialty area that you can move into. Most of what we've talked about today has been the plumbing aspect of the heart. It's very important. That's where the arteries become not functional anymore because they have occlusive or stenotic areas in them. But one of the areas you can specialize in is electrophysiology. And instead of looking at the plumbing, you're looking at the electrical side of the heart. So just as many patients have problems with their electrical systems, either the way it fires, or it fires too rapidly, or you have different conditions that cause it to fire very erratically. So I'm sure you've heard of your family or someone who's had pacemakers put in, or have had implantable defibrillators placed in their chest. So electrophysiology is the area that speaks to that piece. So they would look at very slow rhythms, which we call bradyrhythms. They would look at very fast rhythms, which we call tachyrhythms. And then we look at devices that can be put into these patients that restore a more synchronous rhythm management between the atria and the ventricles. Here we have a snapshot of what the actual room, procedure room, and control room would look like. You have a monitoring person here. She is responsible for communicating with the people in the procedure room. They have a speaker in that room where they can also communicate with her. She is recording every event that occurs. She's watching the different blood pressures here. She's looking at the different EKGs here. And if you look here, she is looking at the images that they're actually acquiring. It's a very exciting field. It's a very demanding field. There's a good job market opportunity there. If you have any more questions about this, just contact someone in our department.